Fatima Memorial System, Lahore. Here I am going to present a case report of tocilizumab for systemic onset juvenile or idiopathic arthritis. It's a case report. It's about Master AI, 9-year-old boy, developed high-grade fever, macular skin rash and polyarthritis in January 2005, which was diagnosed as systemic onset juvenile idiopathic arthritis. At presentation to our clinic in July 2009, he was on oral methotrexate 12.5 milligrams per week with oral prednisolone 15 milligrams per day since the diagnosis of the disease. However, as he was recovering from an attack of varicella and therefore asked to return after this settles, but unfortunately he was lost to follow-up till February 2010. At that time when he visited us, we increased his methotrexate to 17.5 milligrams per week and switched to parenteral route. Plus cyclosporin was also added, 25 milligram twice a day, continuing previous oral dose of prednisolone with naproxen sodium 15 milligrams per kg in 2 divided doses. He was also pulsed with IV methylprednisolone 30 milligrams per kg 3 weekly for 3 months.
Carpal tunnel syndrome, capsulitis and tendinitis. The frequencies in the cases and controls were taken and they were compared together. Coming to the results, about 62% of the 151 diabetic patients, they turned out to be normal, whereas 38% of the patients, they showed abnormalities of hand and shoulder. Out of them, 14% showed only hand abnormalities, 15% showed the shoulder abnormalities, and 9% of them had both hand and shoulder abnormalities. Coming to the frequency of these abnormalities, we can appreciate that
Then he was switched to monthly pulses at the same doses. After 7 months of this therapy, he had a 40% improvement in PGA, that is Physician Global Assessment, and the parents' VAS. However, despite methylprednisolone pulse therapy and optimal doses of DMARDs, his disease was not achieving remission. Therefore, in August 2010, when he had a flare of his illness, again with high-grade fever and polyarthritis, a decision was made to add on tocilizumab, which is interleukin-6 monoclonal receptor antibody. After counseling and informed consent, a fortnightly infusion of 8 milligrams per kg of tocilizumab Actemra was added onto the combination therapy of monthly IV pulse methylprednisolone and methotrexate 17.5 milligrams per week intramuscular. Within a week after the first dose of the infusion of tocilizumab, the patient showed marked clinical improvement with decrease in swollen tender joints, improved joint range of motion, and resolution of his fever. Although after third dose of tocilizumab, he developed a maculopapular rash in armpits and popliteal fossa. This resolved within a few days without treatment. Cause of rash remained unknown, but the treatment was not interrupted. Up till now, a total of 9 doses of tocilizumab have been given to the patient. To date, there has been no flare of disease. All the disease activity indices used to assess disease severity in JIA have been minimal on this treatment, as I'll show on this table. This table is basically showing a comparison before tocilizumab Actemra and after Actemra. In this, clinical parameters, initially he was having fever in the ranges of 100 and 102 degree Fahrenheit, but afterwards up till now, he remained afebrile. As far as the active joint count was concerned, he was started before Actemra, he was having 30 active joint counts, 15 tender, 15 swollen, but now at the end you can see that there is remarkable difference. It's 3 active joint count, 2 tender and 1 swollen. Number of joints with limited motion was 6 and later on it was 2. Similarly, in the lab parameters there was improvement. Hemoglobin remained at 11.8, it was in the beginning, and at the end of the therapy it was 13.7. I would like to highlight ESR. It was 55 before Actemra, but after it dropped to 5. The visual analog scaling by patient's mother, it was 100% before Actemra and now it's 10%. Similar is the case with physician global assessment. It was 65% initially and now it's 10%. Childhood health